Thank you so much for joining us today. I am Dr. Fatima Rodriguez. I'm an associate professor in cardiovascular medicine and the vice chair of clinical research in the Department of Medicine. And in an effort to build a supporting community among researchers who are interested in health equity, Stanford Medicine hosts a number of health equity, action and leadership, or HEAL network events throughout the academic year. One of our HEAL network goals is really to highlight health equity research through this webinar series in collaboration with our Stanford CME program. And it is my absolute honor to introduce today's speakers, who is one of my closest mentors, collaborators, and friends. Dr. Hernandez-Boussard is an Associate Dean of Research and a Professor of Medicine, Biomedical Informatics and Biomedical Data Sciences, Surgery and Epidemiology and Population Health at Stanford University. She has a rich background and vast expertise in biomedical informatics, broadly defined, health services research, and epidemiology. And she's really been at the forefront of advancing healthcare through the development, evaluation, and application of innovative methods. Through her research, she aims to effectively monitor, measure, and predict equitable healthcare outcomes. By leveraging real-world data, her team works diligently to construct a solid body of evidence that can significantly enhance patient outcomes, streamline healthcare delivery, and provide valuable guidance for health policy decisions. In addition, Dr. Hernandez-Boussard focuses intensively on how we can mitigate bias and enhance equity with artificial intelligence and applications in healthcare settings. And she, along with her team, have really developed frameworks for us to think about how we're evaluating algorithms. Her research and evaluation of AI technology really advances healthcare practices while ensuring that all of our populations receive equitable resources, care, and outcomes when the AI solution is implemented into our healthcare system. So now I'm delighted to turn it over to Dr. Tina Hernandez-Boussard, who will begin her presentations. Thank you, Tina.
Thank you so much, Dr. Rodriguez. It is a pleasure to be here and have this opportunity to share some of the work we've been doing and how we think about building responsible AI for healthcare solutions. I am going to share my screen. Can you all see that?
Yes.
Perfect. Okay. So let's get started. First, I just want to start with a little background about me. Thank you, Dr. Rodriguez, for the long introduction. So I come to you today wearing three hats, basically. First, I'm the Associate Dean of Research for the School of Medicine. And that means that I'm leading our health informatics section of our Clinical Translational Science Award, the CTSA Award. I also lead the informatics and data resources for the School of Medicine, and I'm advising on health AI. In addition, I'm a professor of medicine and biomedical informatics, where my group works on optimizing real-world data for use to develop and evaluate AI tools. We have a large focus on responsible AI and how we think about AI deployment. And then I also have a group of students and mentees that I work with. In addition, I'm an advisor for NIH, for the director of NIH, where I am advising on artificial intelligence, strategic data planning, and the informatics needs for NIH as a whole. So through these different roles, I've come up with some strategic sort of frameworks for how we think about responsible AI and ensuring that the tools we develop benefit all populations. So let's get started. As we know, there we go. As we know, AI has a growing role in health and healthcare, right? It's transforming healthcare at an unprecedented rate, from predictive analytics to clinical decision support. AI is now deeply embedded in every application of healthcare. And this landscape is really underpinned by machine learning, natural language processing, and computer vision, trying to make healthcare safer, faster, and more precise. But I think when we start looking more closely at these specific tools that are being integrated into the healthcare system, it's important that we have a holistic view of the AI lifecycle. All right, we need to understand how these tools are developed and how we ensure their responsible use. Now, mostly people focus on model evaluation or model development when they're evaluating AI tools that move to healthcare. But I think it's really important to understand these key concepts or these key pieces of the AI lifecycle, from data creation to data acquisition, model development and evaluation, and also model deployment. Because from data to impact, each stage of the AI lifecycle demands equity checks. Because when bias gets introduced in one stage of the AI lifecycle, it can be amplified downstream. So, um, to get us started, I want to start by really confronting sort of an uncomfortable truth. And that is that for the most part, the tools that we develop, the AI tools we develop in healthcare, are for a convenient population. What does that mean? That means that data diversity is not systematically evaluated. Model deployment is understudied. And policies and standards and guidelines are limited, right? Unfortunately, the tools we're developing today are being developed on white, uninsured urban patients. They're being studied in academic hospitals. And we're developing local standards and policies that lead to inefficient variation when we move across geographic settings. But it's important to note that when AI fails for certain populations, it's not just that we get inaccurate predictions, it's that we really amplify real world harm, right? So true leadership in the field means recognizing that equitable AI isn't just a bonus feature, it's the minimum viable product for any healthcare application. Because true diversity means centering all vulnerable populations, right? Because AI built for the average patient means that other patients are going to be harmed. And I'm not just talking about racial and ethnic minorities. In my lab, we also study all types of vulnerable populations, including patients with mental health illness, obesity, diabetes, disability, etc. And so if we don't ensure that our AI algorithms work across these populations, we are bound to produce harm for these patients. And so this brings us to our first critical juncture that I want to talk about today, and that's the data itself, where bias begins and where solutions must start. So I want to talk about three responsible solutions for AI today based on our AI lifecycle. And let's start with data and data representation. So it's important to understand that data is never neutral, right? Data is a social artifact. Healthcare data sets are reflecting of historical inequities. And when we use these data, we're not just analyzing data, we're inheriting these social practices. And many of these past practices might be unacceptable today. So it's really important to understand that data is not objective, and the data used to train our models is not objective. Every data set used to train our models is a mirror of who society values and who it ignores, right? And so we've done some recent work in Nature Genetics looking at genomic data, and it's as of today, about 90% of all genomic data comes from populations of European ancestry. And so when we start using these genomic data to make precision medicine, right, this becomes a luxury good. These gaps aren't accidents. They're the direct result of who gets studied and who gets included in these studies, which often reflects who is insured, who has access to the healthcare system. So understanding data and the data used to train the model is really important. And this is becoming more and more important, and these gaps in data are becoming more crucial. We recently, I had the pleasure of working with a group here at Stanford where we developed a large language model on genetic code. So the first model was trained on eukaryotes, the second model was trained on prokaryotes, and what we can do with this model is we can actually accelerate drug discovery, gene modifications, and generate new genetic code. And so when we're developing this model, we were really concerned about using the human reference genome that was over 90% European ancestry because we wanted this model to work for all populations. Therefore, we did some really innovative work by using evolutionary species to train the model. And we actually were able to show that in this model that didn't include the human reference genome, we were able to show that our model generalizes comparably across human populations. So it's important to note that this was an exception to the way models are usually trained, but we made a big effort to try and ensure that the models worked for everyone. Because when data are not included in our models, when we are lacking certain populations, that means the models don't work for these populations. We've done a lot of work looking at adverse outcomes following chemotherapy. And what you see in this heat map is that you see that based on race and ethnicity, we see that the model performs really well for certain populations and not so well for other populations. So for non-Hispanic white, you see our accuracy is 0.95. When we look at Black, it goes down to 0.85. When we look at Native Americans, it goes down to 0.8. And so when we look at our receiver operator curve, which is the graph on the right, we see that what happens when we start looking at these different populations, here we're looking at insurance categories, we're over predicting adverse outcomes for certain populations. And so what does that mean? That means that for these populations where they're not accurately represented in our data set, and our algorithms do not work as well for them, they're missing opportunities for care. They're missing opportunities for equal treatment. And we're predicting that they're more likely to have an event than what really happens in reality. So we're causing harm to that population. A lot of times we use data proxies to study populations. So what is a data proxy? A proxy variable is a variable used instead of a variable of interest when that variable of interest cannot be directly measured. Right? And so proxies are built on assumptions about what a variable might represent. And we see this over and over again. For example, it's very difficult to measure need of care. So we've seen algorithms that use cost of care to represent need of care. But that proxy needs to take into account that there's certain populations that spend less on care for the same sickness than other populations. There's been a lot of work looking at arrests and as a proxy for criminal behavior. It's the same thing. There are assumptions that arrests are going to equal criminal behavior, but what we see is arrests actually are more associated with the number of patrols in a particular neighborhood. Let me give you an example of how this comes to play in our healthcare algorithms. This was some work we did looking at vaginal birth after cesarean section, the VBAC calculator. So the VBAC calculator included race and ethnicity as a predictor of a successful vaginal birth after cesarean. And the race was included because Black and Hispanic women were thought to have higher risks of adverse outcomes. So they were given half the odds of a success compared to white women. So what does that mean? That means that we had racial disparities. That means that Black patients and Hispanic women had higher cesarean rates, and they also were provided less treatment options. So the calculator encoded racial differences, enforcing inequities rather than addressing root causes. Well, about 3 years ago, people really started to digging into this to understand why are we using race in these calculators? And it was found that race was actually a proxy for chronic hypertension. And so when the calculators were updated, the algorithms actually improved for all populations because all populations have chronic hypertension. And so this is an example of how using these race proxies really cause disparities in how our algorithms work across populations. And of course, we can't talk about biases in data without talking about large language models. So we've seen how biased data and algorithms can reinforce systemic discrimination, but the problem isn't unique to prediction tasks. In fact, similar biases lurk in the tools we use to process language. So word embeddings, for example, which are the backbone of our AI language models, such as our large language models, ChatGPT, etc. So we have to ask, do our machines inherit human prejudices? And they do, right? And so it's really important to understand that large language models or these generative AI models can weaponize our own clinical documentation, right? We looked at, in some work we did looking at mental health notes in 2004, we found phrases like non-compliant embedded with racial biases. So when Black patients were described as refusing care, the models associated this with non-adherence 68% of the time more than for white patients, right? And so these biases get encoded in the large language models that then get amplified in the tools we develop from them. Another example in our work from the mental health data is when the clinical term patient refuse was in the clinical notes. For Black patients, it was associated with non-adherent. For white patients, it was associated with engaged. So these type of biases get embedded in our healthcare system, which means we have to really face a choice, right? Will we let these LLMs hardwire healthcare's biases over and over again, or do we need to take matters to intervene here? Which brings us to our next point that I want to bring up, which is, AI deployment and utility. So we have a large gap in which tools get deployed into the healthcare system and which tools fail. And let me just give you an example of why some of these models fail. So in Epic, a vendor for electronic healthcare records, created an early sepsis model, ESM. And this model involved over 77,000 hospitalizations and had a sepsis incident rate of about 5%. Now, when the model was created, it had an area under the curve, so its ability to discriminate was about 78%. So it fairly well was able to discriminate who was going to have sepsis and who wasn't. However, once that model was deployed, that ability to discriminate between those with sepsis and without sepsis dropped down to 62%. And what was found when it was actually further interrogated, that the model included variables that were both from before and after clinical recognition of sepsis. So after the algorithms excluded some of these variables that happen after you suspect sepsis, such as specific blood tests that are going to be ordered when you suspect sepsis, once those were removed, the algorithm dropped down to 0.47, so 47%. So you would have a better odds of flipping a coin than using this prediction model to understand who has sepsis. And so this is what happens when we try to move our models to point of care, because it's like going from a petri dish to a population and to a population environment. And there's a lot of steps that need to be taken to ensure these models work well across populations. So here's some work we've done with Brigham at Harvard and here at Stanford, looking at an AI deployment for clinical care and using an RCT framework. And we said that before a model goes to point of care, it needs to go through 3 phases. The first phase is about safety. This is pre-deployment, planning and preparation, engaging diverse stakeholders, comparing training and target populations, developing strategies, really ensuring that your model is safe in the research environment. The next phase is about effectiveness, right? Testing in real time. This is where we deploy the model in a small, controlled environment, and we look at it prospectively to see how it's performing. When do the clinicians want to see the results of the model? How do they want to see it? Where do they want to see it? The third phase is broad dissemination, looking at efficacy of health outcomes. This is expanding deployment across multiple settings, comparing outcomes between the AI tool and standard of care, and really maintaining transparency with stakeholders about model performance. And then phase four, the last phase, the last phase of the model is post-deployment evaluation and how we sustain improvement. This is about long-term studying of the outcome and the performance of the model. And this work was just published in MPJ Digital Medicine. I'm sorry, the reference isn't there, but it really allows us to start thinking about how do we safely deploy these models into point of care. And as I mentioned, this is really one of the key components of this is having community engaged AI. So we've been doing some work with the Alaskan Native communities up in Alaska by Anchorage to understand how can we build tools that are appropriate for their community. And we found it's taken a long time to build the trust with their communities. It's taken a long time for us to get them to trust that we're not going to take their data and use it for our benefit, but we're really going to use it for their benefit. So this is really a transformative opportunity because we're developing tools. Here we're specifically looking at medvac utilization in rural Alaska and understanding if we can build tools that can better help triage patients that need to be transported to the hospital. But there were a lot of concerns from the tribal capacity about AI security, how we're using their data, how we're building these models. But we've really come up with a great strategy for doing this and working with the community advisory board of the tribe. And so I think this is really a blueprint for how AI and machine learning deployment can take place in marginalized communities. In addition to community engagement, as I mentioned, it's really important to have real-time monitoring systems. So we've built a tool for how do you monitor that system once it's in place, right? And so what we want to know is the model robust to data changes over time? And healthcare data is constantly changing. We have new codes, new treatments, new drugs that become available. So you need to ensure that your model is continuously adaptive and flexible for these new changes. We want to know how many years do we need to use to get the best prediction of our algorithm. Given this continuous change in the healthcare system, we need to be flexible on our training data and the length of our training data. There's noisy features. For example, we were evaluating one tool that was being deployed in the healthcare system, and it was still using ICD-9 codes for identifying disease. Well, as you know, ICD-9 has been not in use since 2015. And so understanding and really going through variable by variable is really important to ensure these systems are accurate and continuously accurate over time. And so once deployed, it's important that you understand failure thresholds for your model. At what point do you need to retrain? At what point do you need to know that this model is not working for certain populations? How do we do subgroup monitoring and model longevity? So these are a lot of things we've been looking at for how we think about deploying the model in real time to ensure it's inclusive across populations. And then the final piece I want to talk about today is policy and standards. Because data is, I think, the fundamental piece of developing these algorithms. We have to have a framework for getting these deployed. But at the end of the day, it's about policy and standards that make these solutions safe for all communities. And so we've been working on a lot of policy and standards, certainly in my role with working with NIH and different communities across sectors. We've been thinking about what are the policies and standards we need to ensure that the tools we develop are responsible and fair across populations. So several years ago, we developed some reporting guidelines because we think it's really important to know that when you develop a model and when you are going to use it at point of care, we need to know the population from which the data were acquired. Again, think about the AI life cycle, where that data is coming from, who's included in that population, but more importantly, who's not included. We use our electronic healthcare records from Stanford University a lot to create models. And it's important to know, who's in that data set, but more importantly, who's not in that data set, who doesn't it represent, so that when you disseminate these tools, you can be transparent about who they might work for, who they might work for, and where we don't know they're going to work. We think it's important that you describe the training data demographics, model design and development, and also how the model was evaluated, optimized, and validated across populations. A lot of times, and more in the past, the majority of the time, models were published and disseminated only with an ROC curve, only with the accuracy of the model. Very rarely did we know who was included in the training data, how the model performed across different populations, and we've seen significant changes in that over recent years. And I think it's important that we continue to push on model evaluations across populations, because if we don't look at that, we don't know how our model will be generalizable, which means how it won't be scalable either. Last year, I did some work with NIH on transparency and explainability for AI models. And we have a paper coming out, I think it's coming out today, actually, in Nature Medicine, that sort of summarizes the highlights of this workshop that we did with NIH. And what we found at this workshop, which was a gathering of experts, that there's real opportunities to expand IRB capacities to cover AI-specific ethics. We need to develop training programs on AI's ethical, societal, and transparency needs. In our medical school education, it's really important that we equip the new generation with how to understand the benefits and the harms of AI. And we need to establish incentives for comprehensive documentation. The meta-analysis, the metadata that's associated with algorithms is key. We talked a lot about model cards, data sheets, and how important those are for model reusability and for understanding the applicability of models across populations. We felt it was really important to collaborate across disciplines to enrich AI governance and address ethical challenges. This means that, we've talked a lot about team science and multidisciplinary teams, and it's more important than ever to include in that group communities to understand societal needs and potential societal harms. In addition, we discussed creating incident databases and proxy variable registries to mitigate risks of AI. Just like the FDA has a database to mitigate harm from drugs or devices, it could be we could have a database of AI models that have caused harm to population, known harm to population. In addition, we've been working with the WHO to really think about global standards for local impact. And so with the WHO, we've been thinking about how do we promote AI, the responsible use of AI across low and middle income countries, right? And so what we've done with them is, or what we're planning to do, our framework is to develop training courses and tools to enhance ethical standards for health AI. We're assisting member states map benefits and challenges associated with large language models for health. We're addressing regulatory fragmentation, and this is a big issue. Because when there's regulatory fragmentation, what we think of fair in one group is not fair in another group. For example, fair AI. The standards are different. So we need to identify global priorities such as equity, inclusion, human rights, and privacy. And we need to ensure that these are at the forefront of safe and equitable use of health AI. In addition, with the WAO, we're working on tailored implementation strategies, right? So they're getting regional consultations to assist member states at local levels to really help them adapt tools to local context. Again, it's about generalizability. And so going back to our data, if our data are not diverse, then the generalizability of our models across geographic settings will not happen. And more important, WHO is very interested in operational sustainability. right? So strengthening the healthcare system infrastructure to ensure the longevity and the effectiveness of these AI solutions, and really to establish accountability to stakeholders. So I think that today I've tried to show you three pillars of equitable AI that I think is the path forward. This includes the data we use for the models, how we think about model deployment, and the policies we need to ensure that our algorithms are safe and equitable. And I believe, I'm not sure if you can see the figures there, but I believe I've used my research as a roadmap, right? So my research proves that equitable AI isn't just a single breakthrough, right? It's an integrated system where every stage reinforces the others. This is how we turn theory to impact, right? We've started to expose data injustices. We've done a lot of work looking at diverse populations and vulnerable populations and how their needs aren't met using our AI algorithms. We've done a lot of work looking at, for example, patients in wheelchairs and pressure ulcers, where those patients aren't included in our in the majority of pressure ulcer algorithms, but yet they're at higher risk. We've looked at patients with type 1 diabetes or mental health issues and how they are predicting of substance abuse for following elective surgeries. So vulnerability crosses all populations. And we built tools to detect, how can we best deploy these models into the healthcare setting, but for the continuous monitoring of them to ensure they're safely deployed and to ensure they're continuously monitored. And then I've been working a lot in policy enforcement, right? How do we think about the policy that needs to be in place in order to ensure these models are constantly safe and equitable when they are deployed? So you can't just jump from biased data to fair policy. You have to understand how these topics or these notions are integrated, right? We have to know where the data come from. We have to know how the model is deployed. What settings can it be deployed in? And we have to have standards and policies to ensure everything is fair across populations. And so that's why our roadmap matters. I think it's the playbook for lasting change. And so to wrap up, I want to just share, this is some work again that I've done with NIH and groups across the community, thinking about guiding principles for responsible AI and how do we develop responsible AI. And we said there's five really guiding principles for responsible AI. The first is the problem formation, right? We need to design questions and algorithms that promote fairness and reduce health disparities. The second phase is data selection, assessment, and management. We need to ensure and so that is, how do we engage patients and communities to ensure they're willing to share their data? They trust the system to share their data. Phase 3 is about algorithm development, training, and validation. We need to ensure that models are tested for biases. They're tested for generalizability. And this is a big challenge when we're trying to move algorithms from an academic medical setting to a community healthcare center where they might not have the same expertise, technology, and resources that we do at our academic centers. And we know that their populations are very different. So how do we ensure that these testing and validation are sustainable across dissemination of our algorithms? The fourth phase is deployment and integration of algorithm in intended settings, right? Explicitly identifying healthcare fairness issues. And the fifth phase is to monitor ongoing performance and outcomes and maintain updated and have an opportunity to de-implement algorithms when they cause harm. Establishing accountability. So with these guiding principles and with our framework for research and the breadth of work that I showed you. I hope that I have given you some insights in how we think about responsible AI, how we think about inclusive AI, and how we think that AI really can benefit all populations across the healthcare system. So I will stop there and I'll be happy to take questions and turn it back over to my moderator, Dr. Rodriguez.
Wonderful. Thank you so much, Dr. Hernandez Pizarro. That was a fantastic presentation of really examples that have touched the care of our patients, really across subject areas. There are so many fantastic questions that are coming in, so maybe I'll take the moderator's prerogative and just ask like a general question. So you spent a lot of time talking about how if AI is trained on biased data, which is the reality of the world, is it just destined to perpetuate harm, or is there a way that we can so debias the algorithm and maintain its level of accuracy?
Yeah, absolutely. So that's a great question. And I always get the question because we do use our Stanford data a lot in the research we do. And we know that Stanford data is biased to a particular population. That doesn't mean I'm not going to use that data. It doesn't mean I can't learn from that data. But what it does mean, it means I need to be responsible in how it's deployed. I need to be responsible in being very transparent about who this algorithm works for and where we have gaps in our training data, where we might not know how this algorithm works. In addition, there's several tools that exist now where you can debias algorithms. You can debias different aspects of your output. You can't really debias data, right? And so there's been a lot of talk about using synthetic data to augment certain populations. And people are very optimistic about that. I'm very cautious about that because synthetic data is just an augmentation of the existing data you have. And so we gave an example in one of our conferences with NIH that if you have 10 Native Americans in your population and you synthetically augment that data to create 100 patients to improve the performance of your algorithm, that is still only based on 10 patients, and those 10 patients do not represent the community as a whole. So there are ways to debias it, but I think being transparent about what is included in the model is the key there.
Wonderful. And we certainly still use the data from Stanford. I
Of
think one thing that
course.
really helps us is to have external validation, in our work together at health systems that are different from ours, right, to make sure the findings are generalizable.
Of course.
So a lot of questions around who is responsible really
Oh.
for ensuring that AI is responsible and unbiased? Is it the people who are generating the training data? Is it the model implementers? Who's responsible?
Yeah, so that's a great question, and I don't think there's a clear consensus on that answer. In the U.S., there have been certain states that have been very proactive in stating, accountability. So developers have a aspect of accountability. Healthcare systems have an aspect of accountability, but there is not one person who is accountable for when something goes wrong. And that's why, going back to what I said, we really need standards and policies to really put the guardrails up so that we can identify when harm might occur. We're doing a lot of work in probing our algorithms to try and identify where they're going to go wrong, right? So proactively identifying them instead of, trying to fix the harm after it's happened. And I think we need a lot more work in that space of really probing, where algorithms can cause harm, where they can go wrong.
In kind of the flip side of that, there's some questions around, are there AI tools that can help healthcare providers be aware of subconscious bias, sexism, and ableism in the moment? And can those tools be used to help provide more equitable care? And if you can think of any specific examples of that.
Oh, absolutely, absolutely. So this is a great question, and there's a lot of work in this area, because we can, and I'll give you a specific example. So a lot of the research I do is on pain management and opioid prescribing. And so historically, there is significant literature that shows for the same type of pain, there's differences in opioid prescribing between a non-Hispanic white and a Black patient, for example, but only if it's subjective pain, or only if it's pain that's not measurable. So headache, migraine, backache. When it's a broken arm, there's no differences. So having a tool that might guide clinicians on, on these differences that exist historically and where they're prescribing is a good way to think about the use of AI. However, Dr. Rodriguez, as a clinician, you do not want to be told how to prescribe medications for your patients, right? So I think there has to be trust, and when we do things like this, it has to be in collaboration with the clinicians, with the healthcare system, to really understand what is it that we want to to present to the clinicians, and how do we want to present it, right? Because you are the one who has the license, you are the one who is prescribing. So are you going to let an AI algorithm change your prescribing? I mean, it's a very difficult question.
Yeah, and I think like the user, to your point, like who's actually going to use the tool should be part of that design conversation. And I'll say in my world in cardiology, this never works, right? When you tell them, do it like this, all the reminders, electronic prompts, like it just, there could be an uptake initially, but it quickly wears off if you haven't kind of
Exactly.
thought about those user preferences. So yeah, but I think like even just telling us there may be a bias.
Right,
I mean, there's some
right.
examples of that, and
Exactly.
yeah.
And the other thing where I've seen AI do real good is AI can better synthesize data. They can better pull information from the past that, as when you're sitting in front of the patient, you might not have enough time to go through all of the past history, all of the relevant information. So there are tools being developed that really brings up these key points about the patient's history that might change the way you think about prescribing or treatment or something like that. So that's a great way to augment the clinical decision support.
Absolutely. And I think in our healthcare system, I don't know if it's still happening, but there was definitely that informatics consult with the green button, especially in areas where there's clinical uncertainty, to just synthesize, summarize a lot of data of patients like this when there's not a clear right thing to do can really be
Exactly.
helpful. Um, of course, there's no way around this question, which is around wearing your hat as an NIH advisor and thinking through the current administration's cuts
Yeah.
on DEI and research and grants and other organizations. What extra safeguards and approaches do you think we can individually do to ensure equity, and how could we still do this work considering the current environment?
Right. And so, that is, well, that's the multi-million dollar question, right? But I think it's important to note when you look at the current administration, what is one of their main focuses is population health, right? How do we think about population health? How do we ensure that patients with diabetes, with obesity, with all of these chronic diseases are really cared for? And this goes back to what I was saying about vulnerable populations, right? Vulnerable populations includes all these different subgroups of patients that are often we often don't include these details in our algorithms, right? And so, for example, we found in some of our pain management work, patients with type 1 diabetes, they have a higher threshold for a higher tolerance for opioids, and therefore they were often prescribed more and more opioids compared to other patients. But they also had a higher risk of prolonged opioid use. So understanding these vulnerable populations is something that I think the current administration is really interested in. They want to be leaders in AI. They want to be leading the innovation of AI. And so, how can we do that? The only way that we can be leaders in AI is by ensuring that our tools are scalable, ensuring they're feasible, and ensuring they work across populations, both in the US and across the US. And that is only going to be done if we have diversity in our training data, and we really have community engagement to get the trust across populations to have their data included.
Thank you so much. So it's still, you can still do the work. We just
We
meaning
can,
to align with the strategic priorities and of course population health prevention. There's a couple of questions around prevention, so I'll kind of shift to those. How do you see these medical models and AI that aims to provide tailor-made prevention and treatment strategies for groups or individuals? Do the same kind of principles around responsible AI apply here?
Well, yeah, so that's a great question. And when we start looking at individual care treatments, right? We've seen sometimes that when we develop AI tools for the general population, they fail for everyone, right? Because there is no general patient, there's no average patient. And so it's really important that when we're developing these tools, that we get really specific information that can target, an individual's needs. There's been a lot of interesting work in this notion of a digital twin. So really looking at the trajectory of individual patients and forecasting how an individual patient might respond to treatment A versus treatment B. That really takes it to an individual level, but that also requires that we have extensive multimodal data for the individual patient across a certain timeline. Because mostly in healthcare, we get spotty information, right? We get information when people are sick, when they come into the hospital, and the sicker they are, the more they come in. But it's really important when we think about that data piece and looking at individual patient trajectories that we capture information outside of the healthcare setting. We capture information on social vulnerabilities. We capture information on environment, et cetera. So really having that detailed multimodal information will help us get to the individual predictions.
It's wonderful. There's a couple of really interesting questions, and it was an amazing audience around the examples you gave around removing race as a proxy from equations. And of course, we've seen this in a lot of other equations, including the
Yep.
GFR calculation for the American Heart Association, the pull forward equations, I mean, that we've worked in now with the prevent equation. So how can AI help move us away from, race as a predictor to all the other factors that we know are associated with the outcome of interest?
Right. Excuse me. So this is a great question, and it's something we think about a lot. Because it goes back to this convenient population, right? And so a lot of times these algorithms are developed using convenient data. That means we don't really have a variable, as we mentioned, for healthcare need. Right. And the only way you can get that is really by going individually patient to patient. It's not systematically captured. And so, therefore, we do see in a lot of these cases that there are differences in outcomes by race. So, you want to look at that. You want to know that. You want to document that. But you can't stop at that, right? You have to understand what is race the proxy for? What is really, because 90% of the times or more, race is not the causal factor here. There's no biological mechanism associated with race for your outcome of interest. It's the social inequities, the social determinants of health that are really driving these differences. And so I think it's really important as we move forward that we have better tools to capture different social determinants of health, be it transportation, be it language barriers, be it education, to really understand what is the driving factor, chronic hypertension, malnutrition, all of these other aspects that can be causally associated with our outcome of interest often are not captured systematically. Therefore, we're forced to use these proxies.
That's awesome. And thank you. And certainly, I think that's where we're going with the risk prediction equation is like, what else can we capture? Some of it is biology, some of it is social determinants. And again, they can causally affect the outcome.
Yes.
I think, this may be one of our last questions. There's a lot of interest in global health and, its inclusion of particular communities. We've talked about it, but how about also less favored countries or less resource countries in development of AI when they may not have all the tools necessary for development? Can they still potentially benefit from the deployment of these tools?
Right. And so this is some work that actually just came out last week we did with WHO, where we're looking at the global implications of how do you promote and secure equitable AI across these countries that have no resources, that don't have the technology or the expertise. And again, I think it comes back to how do we develop models that can generalize across these populations? How do we develop tools that these other nations even here in the US, community hospitals, rural hospitals, right? How do we ensure that they can pick up our tool and be sure that that's going to work for their population? So I think this is a technology challenge that we can definitely solve. And that is, how do we understand how tools can be generalizable across different populations and ensure that, they're not going to cause harm. And if there are no tools that address a specific problem, well, that's a great opportunity for research and for people like us who love to study these challenging questions. But I think it's really important that the WHO is working on really trying to harmonize the standards and the regulatory aspects of global AI. Because if each country develops their own standards, if each country has their own specifics, then you get this variation that's very hard to operationalize from a larger point of view.
And to your excellent point around like thinking of this like a clinical trial, when you say like the phase 4 post-deployment evaluation and surveillance,
Yes,
that's a key thing, right? And if there's no framework to see how it's different across the country, it's hard to fix. And there may be that there's like local solutions for each of the obviously the
exactly.
context matters, and you've taught me this may need to be adapted. Well, that's fantastic. I know we have many more questions, but I think we've highlighted the general themes, and I think you guys can all agree that this has really been an amazing conversation with Dr. Hernandez-Boussard. And she will be delighted to share all her presentation slides with the group,
Certainly.
so you can see in particular how to look at these frameworks, to look at your own questions and AI use cases in your clinical practices and research practices. We thank your attendees for this engagement today. I mean, we just have so many wonderful questions and clearly sophisticated questions, a sophisticated audience. And we look forward to providing additional opportunities to join forces on health equity research throughout the rest of the year.